This podcast was proudly brought to you by Bioceuticals, leaders in nutraceuticals and education for healthcare professionals. This is FX Medicine. I'm Andrew Whitfield-Cook. Joining me on the line today, all the way from sunny, wintry Melbourne, is Alessandra Edwards, who's a clinical naturopath, Western herbalist and nutrigenomic specialist with a specific interest in digestive health, mental health and their interaction with the microbiome. Born and raised in Italy from a French family and having fallen in love with Britain, you get the immediate sense that Alessandra Edwards is not one given to the status quo. She's a searcher and researcher of natural options for complex disorders. She's worked in the natural health industry for over 10 years, both in the UK and Australia, where she runs Reclaim Your Health, a busy nutrigenomic and nutritional clinic in Melbourne Bayside. Alessandra utilises an integrative approach to practice, combining specialised blood testing, genetic profiling and gut microbiome sequencing to formulate personalised health plans. She works with a number of highly regarded integrative medical doctors and speaks regularly on nutrigenomics, gastrointestinal and mental health. Today, we're discussing how to treat kids with GI conditions. No small subject. Welcome back, Alessandra. How are you?
I'm great, thank you. I'm wearing my thongs and a jumper.
I can't get over Melbourne. We're having a heat wave in Sydney. It was supposed to be the eastern states, and you've gone from what temperature down to, did you say 17?
It was 16 this morning and it was 33 last night.
Oh my goodness. Wow.
That's Melbourne.
Yeah, that is. But I've got to say, a fantastic place on earth. I love Melbourne.
Oh, it's wonderful.
Now, on to our subject. And as I said before, this is no little kitten, this subject. This is kids don't have the faculties to describe what's going on, even in their tummies, let alone anywhere else. So I've got to ask the beginning question, and that is, how do you start with a consultation with kids with gut issues?
Okay, I cheat. I usually I speak to the parents.
Yeah.
It really depends on the age of the child.
Yeah.
So if we are talking about toddler age, so, anything below the age of 2, then generally the parents have been alerted to the fact that something not quite right. And typically the child seems a little bit off colour, perhaps they seem like a little bit fussy in their eating habits, or they've lost their appetite, or typically in that age group, the parents have noticed that there's something not quite right with the bowel movement. So either they're a little bit constipated, or they've noticed there's some loose stools or a fainting smell or something like that.
Yeah.
The other side of it is that often I see children who have chronic digestive issues, and so in that case, often it's actually the integrated GP who's contacted me ahead of time. And so we've had a telephone conversation. So I already know what I'm looking for. And thirdly, I tend to always speak to potential clients before agreeing to work with them. So in the case of children, I always have a conversation before even the initial consult on the phone. And I do this because I'm acutely aware of the things that can be missed in terms of children's health. And so I do this as part of my onboarding triage process, where I can quickly work out red flags.
Yes.
So that I can refer them to the GP and say, look, I really think that you should, discuss this with the GP because you need to do this kind of testing, and then come back to me once the GP has given you the all clear.
Correct.
And I think that in this kind of current climate, particularly this year, it's really important that we uphold, really high professional standard when it comes to paediatric health.
I could not agree with you more. And it was actually one of my questions I had to ask you as a registered nurse, because, we've seen the issue with Marilyn Bodnar, who, I can't agree with that sort of treatment with anybody, let alone a child. And what annoys me, though, is the way that the media picked up on that she was a quote-unquote naturopath. Well, she's never done any formal study on that as far as I can determine, but she was apparently a midwife. Nothing about that in the media. And by the way, she doesn't appear on APRA. So she's certainly not a currently registered nurse midwife. So I don't know what they mean by the term midwife, but it was, to me, I was quite annoyed at the way that they, targeted naturopaths, properly trained naturopaths who are trained in safety, and blamed her actions for an industry which actually has a better standing than what she was doing.
Yeah, I completely agree. I think that it was a bit of a shock to many people in the industry how the whole thing was portrayed. And I think, from my point of view, I think what we need to do is really, raise our profile as complementary professionals. And to do that, we really need to uphold the highest standard of practice, in our own professional life. And so I think even more so now, even more than ever, we need to question everything that we do in clinic, everything we say. And particularly now in Victoria, with the new Victorian Health Complaints and General Code of Conduct, I know there's been a lot of people not happy about this in the industry. But actually, I think it's important that we have these codes of conduct. Because we're not registered as a profession.
Absolutely.
And so, having these codes of conduct really makes you think in terms of, I could be open to litigation, and I really need to think carefully about what I do and the kind of treatment. And first, do no harm. And remember that, we're not general practitioners, but we are complementary practitioners. So I think that it helps redefine the scope of practice even more. And I'm all for it. I think it's a great thing.
Yeah, and I think it's a good line, a demarcation line for our industry. We are not doctors. If you want to be a little doctor, go and do medicine and take on that responsibility. Yeah. But can I ask first about these red flags? Because kids are renowned for going off the boil quickly. They can't often tell you or demonstrate to you where the pain is or what's actually happening in their body. And indeed, you can't see that, even on the best examination. So what sort of things might you suspect with certain symptoms? Things like, intussusception, like let's say a Crohn's, even rheumatoid arthritis can present with gut symptoms. So how do you look at red flags? What do you sort of look for?
Okay, the main things that I really look for are, first of all, diarrhea, how long it's been going on, how severe it is, and has this been flagged with the local GP? Is there a possibility that it's, a food poisoning case or an infection kind of case? I ask questions related to appearance of the bowel movement. Is there blood in the stool? Is there mucus in the stool? Other things that I look for are weight loss, failure to gain weight, sudden fevers. And with things like intussusception, generally, I've never had a case like that. I think it's relatively uncommon. But to look for would be severe pain. So anything where, so even though a young child might not be able to point where it is, they would be aware of severe pain.
Yeah, inconsolable.
Yeah, absolutely. So those would be the main things. And the other thing also that might ring alarm bells, even though the child might not present with some of these particular symptoms, would be actually taking a really detailed family history. So if there are things like rheumatoid arthritis or Crohn's disease in the family, then my alarm bells already are a little bit on the... they're a little bit, what's the word, activated.
Yeah,
that's right.
Yeah. You mentioned, I think, vomiting. There's certain criteria that we've got to look for with regards to how often a child vomits within a certain time period, particularly in an infant, so that you can get appropriate intervention before they go off the boil in a really bad way with regards to electrolytes. So what sort of things do you look for there? What sort of signs do you tell the patients to look for with, skin turbidity and all that sort of thing?
Yeah, well, look, it depends on the age of the child. I'm super cautious with vomiting with infants. So if it's something that has been going on for more than a few hours, and the baby is appearing to have sort of sunken eye, sunken fontanelle, starting to look lethargic, I straight away I refer that you really need to go to ER now and get the proper assessment, because I think that it's just not safe, and I'm not in a position to give that diagnosis whereby I can reassure the parent that this is going to be okay in a child that young.
That's right. So given that you're not, emergently concerned about this child, what examinations, apart from a detailed family history, what examinations do you undertake?
Okay. First of all, I would say in terms of the family history, one thing I would like to flag up is that it's really important to go through a detailed medical history of the mother, and particularly also of the preconception time, and how healthy she was in pregnancy. Were there any medical interventions in pregnancy as well? What type of birth the baby had, whether they were breastfed, were there other medical or drug interventions in the immediate postpartum period, or certainly in the first 3 to 6 months. I also look particularly for things like utilization of proton pump inhibitors in babies, which is really, really common practice now. So I would say probably, 4 out of 5 babies I would see who've had, seemingly digestive issues have been given a diagnosis of reflux and been put on a PPI. And I think that it's a bit dangerous doing that, and it's a real shame because often more obvious things are actually missed. So I'm finding that very commonly breastfeeding issues haven't even been investigated.
Wow.
And so, and I've seen this a lot, and it's happened, quite often that by then getting the person to, the parent to go and see a proper lactation consultant and paying for it privately, that they discover that actually there are latching issues. And so the child is developing really, a severe gas just because of the ratio of sugars that is coming through the milk.
Yeah.
And so it's not really reflux at all. It's a breastfeeding issue.
Wow.
And then we know, obviously, that intervention earlier on with PPI sort of sets the stage for, the follow-up with dysbiosis and some young children also with small intestinal bacterial overgrowth. So I would say, keep your radar on for those kinds of things, and don't assume that just because a pediatric gastroenterologist recommended the PPI that was necessarily the correct diagnosis. It's okay to revisit that and discuss it with the general practitioner and try these other measures that would be helpful. Obviously, wouldn't recommend for the client to stop the medication. We can't do that. But at the same time, exploring the other avenues that could be actually more helpful.
Yeah, just a little bit of good news, I guess, on that front, and that is that Medical Observer, this is 14th of December 2016, a hike in the use of proton pump inhibitors amongst older Australians over the past couple of decades is now tapering off. So hopefully this will translate. Great. Yeah, hopefully this will translate to the younger generations, of course.
That'd be wonderful.
Yeah, wouldn't it?
That would be really, really great.
I think it's really interesting that in my day, and we didn't have the proton pump inhibitors, but we had the H2 inhibitors, Zantac and things like that. In the MIMS of the days, they were never supposed to be used for longer than 6 to 8 weeks.
Oh, wow.
Find that. Find that these days.
No, that's right, usually for months.
So what would be the top 5 most common things that you actually see presenting in kids? Okay,
so in terms of symptoms, usually constipation and diarrhea, or a combination of both will probably be my top 2. Abdominal pain, as self-reported. And then things like encopresis, also I see quite a bit of that. I'm not sure how many of that. That's probably 5. I also see quite a bit of recurring worm infections. so the ones that don't clear very easily. There's a number of things, and then obviously on the rise, really food intolerances. And if I could get on my soapbox for another few seconds again, I would just like to mention this growing concern of mine, which is salicylate intolerances. I'm now basically every week I'm seeing a new person who's diagnosed their child with salicylate and amine intolerance, and they're convinced that the child has, these severe intolerances. So then they go on to this highly restrictive cell-safe diet, and they feel that the digestive symptoms abate, and then the child also starts sleeping better. And so I see children who've been on these diets where they're eating basically about 10 different foods for about between 3 and 6 months. And it's a real concern for me, because that's where severe nutritional deficiencies occur, and in children they can occur really, really quickly.
Yes.
So I would just like to really flag this, and again say, just because a little child is with the mother and the mother has given a self-diagnosis, you don't necessarily have to accept that, and to question it and dig a little bit deeper, because I really do not believe. Actually, I personally do not believe that salicylate intolerance is a thing.
Right.
I think that it's masked by other things. I think that there are often histamine intolerances that are masking the salicylate, and because they do the elimination combined, so they eliminate amines and salicylates at the same time, then they feel that the salicylates are part of the issue. But generally speaking, it's more related to a dysbiotic picture, and where there are profound shifts in microbiota, and by removing even more sort of different kinds of prebiotic foods and foods that are high in polyphenols, which feed beneficial bacteria, then they end up stuck in this cycle where they have they're feeding more and more bacteria that produce things like amines, and so they become more and more convinced that the problem is actually the intolerance, whereas the problem was the gut in the first place. Yeah.
You know what? I've seen this or suspected this on a number of things where the new flavour of something comes in, and we intervene in a certain way and think that the changes that we see are therefore due to that intervention. But what happens is, or what the real issue is, that we're changing an overall thing, and so the changes are really due to that, but we think it's due to one thing. For instance, the French paradox I'm going to talk about, and they went high saturated fat but low heart disease, so therefore high saturated fat's good. Well, hang on. When you look at the French diet, they eat slowly, without stress. They eat a lot more vegetables. It's not just the saturated fat. So there's all of these other things. So it's much more attuned to the Mediterranean style eating rather than this saturated fat that's the answer.
Absolutely. And lifestyle.
Lifestyle.
They've got a much shorter working week. Absolutely. I think stress is a huge component, but we tend to latch on to these these results and then make decisions as a result. And so I think we've spoken before about how trendy it is now to have high saturated fat everything. And I have experienced it firsthand, personally, and also in clinic. I experimented with this years ago, and it was disastrous, absolutely disastrous. So I think that a little bit of common sense in our approach probably wouldn't hurt.
Yeah. You mentioned encopresis before. I just wanted to point out for our listeners that that's the soiling of underwear past toilet training, correct?
It is, yeah. So it's involuntary soiling, yeah.
Yeah. So I've got to ask about psychological issues here. A new sibling or some other, even a sinister, sexual interfering with the child or anything like that. Do you ever sort of have to, be a little bit cautious in your questioning of the parents here to get to the real issue?
Yes, absolutely, and particularly because I'm not trained as a psychologist. So I've I have never been confronted with something like this in the sense where I thought that there was something untoward just because we saw the results. You know, the increases was resolved. However, I would say you would definitely, as part of your case taking, you would be asking sensitive questions as, you know, are there any potential stressors in the home that you think could be contributing to this? Tell me a little bit about the family situation. So those kinds of things. And certainly psychology and nervous system health are really intertwined with encopresis, and often that is all that is required. But from my point of view, I tend to see the encopresis children who have done all the testing and nothing has worked.
Right.
So, and really, I'm always surprised as to something as simple as a parasite test that has been missed by all the, you know, gastroenterologists, the children's hospitals, and no one has actually done a very simple parasite test.
Wow.
And these children actually harbour a parasite. So they're calling themselves for a reason. It's not really encopresis. They actually have an infection. So I always find it always amazes me when I see that.
Look, you know, this is one of my beefs, is that the medical, I'm going to say industry, profession is taught common things happen commonly. The problem is that you tend to, many practitioners, and not just medical practitioners, would tend to therefore always, or you know, for the vast majority of times, look for the common thing, rather than always suspecting that, you know, my answer to that is common things do happen commonly, but sinister things will kill you before the common things. So, my issue is, if I can't see it, if I don't know what's going on inside that gut, I want some test to reassure me that I'm not doing a placative type treatment where something horrendous is going on that will affect that family and that child forevermore. You know, that's where my sort of, call it paranoia, sort of steps in. And that's why I really like what you do, that you cover your bases before progressing. But then can I ask, with regards to treatment, when do you tend to revisit treatment, particularly with kids who can go off the boil and come back on again quite quickly? And then how do you tease apart let's call it a placebo response. Let's call it a subjective, they're listening to me, they're doing something, whereas before nobody's listened to me, so I'm happy, there might be less stress, and so the child feels less stress and gets better, versus a parasitic type issue that's a demonstrated pathology that's getting objective response. How do you tease that apart?
Well, firstly, I agree with you. You need both, and I've actually got a little anecdote for you to illustrate my point.
Yeah.
I was recently speaking to the mum of a little client, a 6-year-old little girl who I've been seeing for recurring worms and constipation. And I tend to follow up my clients on a weekly or, you know, every 10 days. So I send them an email to see how they're progressing, if they have any questions. And so I remember checking in with this lady, I think it was about 3 weeks into the treatment, and the mum was adamant that there was no change.
Yeah.
And so I took that on board. And I thought, okay, well, we might have to revisit the treatment and I'll have to reassess. And then I thought, well, hang on. She's 6. She's 6.5. She's actually nearly 7. So I thought, let's actually ask the daughter. So I emailed her back and I said, well, you actually asked her. And it turned out, in fact, she had started emptying her bowels much more regularly. She hadn't had an itchy bottom, you know, for a couple of weeks.
Yeah.
So I think it's important to do both. In terms of revisiting testing, I tend only to do that in terms of parasitic infections and when there have been gross nutritional deficiencies. Otherwise, I base sort of my treatment review on the clinical presentation and how the symptoms are progressing.
Yeah.
As to whether, you know, how much of it is placebo, how much of it is actually biochemical, I don't know. And really, at the end of the day, I'm not really sure that I care that much, because what I want to see is results, whichever way they come. And I think that's part of the beauty of being a complementary practitioner, that placebo effect probably plays a big part, because we counsel the clients During the consultation, the little patient might be sitting on the floor, listening to what's being said about them while they're doing some drawing. And so it is part of that holistic, we're here for you, we're listening. And so, as you pointed out, it could be that their stress response just gets abated by noticing that someone is paying attention.
Yeah. I think the big thing there is longevity of results. Like I've been to medical practice, I've been to physios, and you feel great after the physio appointment because they're supporting, the movement of the spine, things like that. Wow, that feels so good. 3 hours later, So, and yet I've conversely to that, I've had other patients, and I'm going to speak from a personal point of view, my wife, who has visited an extremely caring practitioner, physio, and she is getting long-term results in between visits. So there's two sides of that quote-unquote placebo coin, Is it necessarily bad? If you want to sell a drug, yes. But if you want to get people better, I think the big issue is longevity of results.
And look, I think that I'm not sure how much an exclusive placebo effect would last in terms of longevity, particularly when we're looking at, a dysbiotic picture. So we know that, that the longevity of the results will also come after the treatment has ended, the active treatment, in terms of, the parents or the client being able to sustain the dietary changes, the lifestyle changes, the mindset changes that we recommend as complementary practitioners. And so self-care is really high on my agenda. And I generally now only work with people on, 4 to 5 months programs, because I have found that in order to cultivate that new mindset of self-care, it really takes a bit of time and working on educating them on actual information as opposed to finding information on blogs written by people who have no clinical experience, no qualification. I find that, with this kind of therapy, you get really, really great results that stick. So they don't come back to see me. Yeah.
So prevention of reinfection. I know we've discussed this before in a previous podcast that I did with you on blasto, but with regards to that prevention of reinfection, when you're looking at the environmental aspects, I remember somebody talking to me about northern rivers. Blastocystis was rife throughout the northern rivers because people commonly, not always, but more commonly than other areas, relied on rainwater, thinking that it was a healthy option, yet it was unfiltered. So I was like, eek!
That's right.
Yeah, what do you think of? What sort of things do you go through here?
That is definitely a big, big flag. I always ask people if they, as part of my initial questionnaire, do they drink tank water? And if so, what kind of filtration system they have? Traveling measures, when do they last travel abroad? Or, are they active bushwalkers? Do they drink from rivers? So those kinds of questions are really important. But from a more urban point of view, also simple things such as, is your child attending daycare? Yeah. To me, straight away, suspecting possible co-infections, worms, that's really important. And assessing also, not just from an infection point of view, but if they're at daycare, are they being fed the food by the daycare? What's the food like there? So those questions are also important. And even in terms of personal hygiene, when you're doing the physical examination, which I think I didn't answer your question earlier about the kind of examinations that I undertake, I was going on about the medical history, but I certainly do a physical examination, and particularly for digestive issues in children where, as you correctly said, they cannot describe what's going on in their tummies. I think that doing an abdominal examination, especially concentrating on observation and palpation, is important, because with palpation, you will be able to sense and see the guarding. If there is an area that has some inflammation or infection or something else. And then looking even at the fingernails, are the fingernails nice and trim? Are they clean? Also looking at the tongue, that's a really, really big part of the examination for me. So going back to the environmental assessment, the other thing that's important that kind of falls a little bit outside of the environment, but who else also might be harboring an infection or parasite in the family?
Right.
Do you test everyone else in the family? Do you know who the carriers are?
Right.
So those things are important because often there are reinfections, and it's important to know that it is very common for families to carry parasites.
Yeah.
And it doesn't necessarily mean that the parasite needs to be eradicated. That's not the aim for me of the treatment. But if the child is more susceptible to actually developing digestive symptoms as a result, and they've had severe diarrhea as a result of constipation, then knowing that there are other carriers in the family is really important.
This is one of the things I love about you, Alessandra, is you've gotten away from that kill mentality. Quick, hit it with a hammer sort of thing, and you're saying, whoa, back here. Let's look at why they reacted. Why have they got an issue where somebody else hasn't? Because, for instance, blasto is this sort of facultative. It's not an obligate pathogen. It's a facultative pathogen which will, take advantage of a poor terrain and say, I'll have a piece of that, thanks. I don't know why these pathogens are always English, but anyway. A couple of things I have to broach with you, though. You mentioned the 6-month sort of program. Motivation very commonly tapers off. How do you broach that motivation factor over that elongated period to make sure that they're on the straight and narrow, and making sure that they're doing the good things, cooking the good food, feeding the good food to their children, avoiding the bad stuff? What do you do?
I watch them like a hawk.
Right.
I actually physically call them. So I'll send out an email weekly to see where they're at of previous interventions. Have they implemented the changes? If they say no, and it's no to a lot of the questions I'm answering, then I go, right, I'm calling in 5 minutes, or let's organise a 5-minute catch-up. And just to help them identify, basically, is there any self-sabotaging going on, or is it really a time issue? Do they need a little bit of coaching in terms of time management and getting their life organised? Is there any help I can help them bring in the home to give them that support?
Wow.
But I have to say, can I tell you something though? I actually screen my clients before they come on board.
Yeah, you said this before.
Because I'm not a psychologist. So if there is someone where I identify where there are really, severe mindset issues in terms of, I'm not worth it, or I'm not going to be able to get better, I've always been unwell, then I don't feel like that I'm best qualified to help them. So I try to refer them to the GP to get a mental health care plan in place first and get them to overcome those psychological barriers. And then once they're ready, great, we can fly. And as long as there's commitment, that's fine. So basically, it's a matter of breaking down, chunking out the steps and the aims and goals. So, if someone's coming to you and with a standard Australian diet and they're eating, white bread and junk food and everything is pre-prepared, they're just eating a bit of iceberg lettuce once a week, you really cannot possibly expect them to be 100% compliant if you put them onto a 100% whole food diet. So I tend to introduce things first. So are they not drinking water? Let's put in the water. Okay, let's bring in some extra veggie sticks a day. Let's have an apple a day. So all the things that they can add so they don't feel that they're giving up their lifestyle. And then bit by bit, we make the changes.
I held you in high esteem before, Alessandra, but I got to say I tip my hat to you, because it's very rare that I will meet a practitioner that will say, you know what, you need somebody else's help first before you're going to have the success with my program. I'm not going to even touch you. And you're not rejecting them. You're saying there are other people who can better help you prepare for when you might be ready to undergo this program, because it involves change. And I really applaud you for that. That's very rare and very well done. Good on you.
Thank you. Thank you very much. That means a lot coming from you. Thank you.
No, my honour. I got to say, I love this job. I do. I just get to meet the best minds. It's awesome. I have to ask though, the bad question that we never like to ask. What happens when things simply don't work and you are confounded? And I'd like to sort of raise a thing here that was told me by Dr. David Jarr. Hi, David. And he said, when things go bad, that's okay. I know enough. I'm confident in my education to say, all right, let's change. When things go well, he said, that's great. I just get a bigger self-esteem. He said, it's when things don't change. He said, when things don't change, I'm dead in the water. I got nothing. I got no signpost. He said, that's the most frustrating thing to me. What do you do to reassess? What sort of things do you do to look at, maybe even find out if there's compliance issues and they might be not telling you the truth?
Absolutely, especially with children. Look, for me, I am, I'll come clean now, I am incredibly competitive. When we go to naturopathic college and even, subsequent years with continuing professional development, you're always told, don't take it personally. So I take it personally. I invest a lot of my time, research into these cases. And when there is, luckily it doesn't happen all that often, but it does happen when there's people that just don't budge at all. I do take it personally, and I do not take no for an answer. So what I do is, first of all, as you said, I check for compliance always. Luckily, as part of these programs that I run now, that's kind of, I assess that on a weekly basis. So I know generally they are compliant. However, sometimes they are non-compliant through no fault of their own, in the sense that they have perhaps misread my instructions, or I didn't make it clear enough. So they might not be taking the correct dosage.
Yeah.
So that's the first thing.
Yep.
Once I've assessed that, then I basically sit down of an evening and I take everything out. I reassess all the tests. I go back to the initial questionnaire and I get my mind map software out, and I just basically reassess the whole case and put it through a fine comb and see whether I've missed any differential diagnosis at the beginning, or if there are some differential diagnoses that I haven't yet explored with testing. So sometimes when the case is really complex, you cannot test for every single possible option. So then that's another avenue. If then I find that that's not the case, and I'm still convinced that I was on the mark with the original diagnosis, then I review my treatment, and particularly the dosage.
Yeah.
And this is something that I think comes with experience. And in the early days, I never used to do. I used to kind of stick to dosage by what, would say on the bottle, if you like. And I think once you have that confidence, sometimes just increasing the dosage or the frequency of the dosage, that might be all it takes. The other thing it could be that, again, something that comes with experience is that perhaps they need a little bit longer on this treatment.
Right.
Yeah. And finally, if that doesn't work, then I've got my two other options, which is I actually pay for a mentor.
Yeah.
So I have 2 or 3 mentors in Australia that I speak with on a regular basis, even with cases that it's not they're not budging at all, but perhaps they're not moving as fast as I'd like. And the other thing is also to have good GPs on board that you can actually call up and say, could I ask a few questions? What do you think of this? So I think that generally speaking, it's rare that I find someone just I cannot help at all after having done all these steps.
So my next question is regarding treatment. You've got several herbs which you've got to be more cautious with in kids, for instance, those containing thujone, those herbs containing thujone. Are there any treatments that you particularly avoid in children because of potential toxicity? Not that I've seen any on the database of adverse events notification, DAEN for the TGA. But are there certain herbs that you avoid? Are there certain herbs that you really like to use in kids that have really good effects?
Yes and yes. Again, it depends on what particular condition we're talking about. So generally speaking, I find that but herbs that I would certainly avoid in children would be things like coptis, for example, and herbs that are particularly non-selective in terms of their antimicrobial action. So I'm not a huge fan for gastrointestinal conditions in children of hydrastis. And with children, I tend to work more in terms of introducing things rather than killing. So I work a lot with prebiotics, different types of prebiotics. I work with individual nutrients. So, things like zinc, for example, or, low dose vitamin A. And I will do that through functional foods as well, or functional supplements like cod liver oil. Herb-wise, I really like sort of fairly low dose in my treatments, and I tend to concentrate on those herbs that actually have more selective actions in the gut, so like punica, and also anti-inflammatory actions, so like chamomile.
Okay, so with regards to functional foods, for instance, things like fructooligosaccharides or inulin, you know, as an industry, it's just inulin. There you go. See you later. That's what it is. But there's different sized molecules. There's different types of these fibres. Do you find that different foods, for instance, work differently, or that you choose different supplements because of a different molecule length?
Yes, absolutely. And look, I've had the great fortune of having, Jason Horlack at Gold's Naturopathic as my mentor now for best part of a year and a half now. So my approach is heavily influenced by his research, and I have to say that the application of different foods and different probiotic fibers in terms of modulating specific bacteria works really, really well for me. And the way I do that is generally by doing a comprehensive stool analysis based on, PCR technology. So you can really have a good idea as to what kind of modulation you're looking for. And so generally speaking, I see a lot of bacteria that really thrive on protein and fat, and not so much of the bacteria that just really love fiber, love coloured fruit and veg, and prebiotic fibers, even in terms of foods, in terms of eating lentils and beans. And that is right across the board. So 9 times out of 10, that is the kind of dysbiotic picture I see. Right. I think we just have way too much availability of meat these days, and I'm not really convinced, looking at this testing that I'm doing, that that's how we're supposed to be eating. So my selection of these fibers is really based on this. So what does the test tell us? What are the symptoms correlating this microbial picture that I'm looking at on this piece of paper? And then how do we modulate, and how do we select, which fiber do we select for that? And the great thing about these fibers is that compliance with kids is fabulous, because they taste like sugar. So they can be eaten off the spoon. They can be incorporated in juices, smoothies, and it's a lot easier to give them that than herbs. Yeah. Although I do use some terrible tasting herbs as well, but not for everybody.
I'll get to the terrible tasting herbs in a tick, because that's a definite trick, that one. But I was really interested. I read a paper, and forgive me if this is wrong, but I get the feeling it was either from Fred, I think it's Barkhead that you would say, pronounce his last name, Fred Barkhead, or Martin Blazer. But what it was looking at was the microbiota over the life, i.e. as we grow, and at different phases of growth, i.e. when you're sort of the sort of infants and the teenage years, these propionibacteria tended to be higher in amounts. So I wonder if it's sort of this, we know about, the maternal microbiota will sort of tend towards the carbohydrate harvesting. And I wonder if there's a function in some of this modulation of the protein harvesting bacteria, dare I say that word, over a lifestyle, with regards to periods of growth, muscle growth in particular. You ever seen this, or?
I think that's a really interesting question. I know what you're talking about, and I think that I read about this. I think Martin Blazer actually talks about it in Missing Microbes. I haven't thought of it in that way, and it's certainly an interesting point of view. Perhaps because my population sample is a little bit skewed, in the sense that I only ever see people who've got symptoms.
Yeah.
So for me, the correlation
Get rid of the
is,
symptoms.
well, it's get rid of symptoms. Also, the correlation is just, I see this kind of dysbiotic pictures not just in infants or children who are in that sort of anabolic state. So I'm not sure, and I don't think we've got the evidence yet as to what that means.
Yeah.
The way I interpreted it is more that in terms of the current lifestyle practices that we all have, we generally have a loss of diversity over the course of a lifetime. And if you like, it's survival of the fittest. And so the fittest will be the ones that get fed the foods that they thrive on a more regular basis.
Yeah.
And so perhaps that's more of the case. I'm not too sure.
Can I ask you then, I guess, sometimes I've heard practitioners say, there's too many lactobacilli. And so therefore the initial reaction for that would be lactobacilli are therefore bad. And my concern is, well, hang on, shouldn't you be looking at why there's too many lactobacilli? Do you ever see this sort of reaction going on?
I get it all the time. There's lactobacillus overgrowth and the streptococcus overgrowth. So let's take, a course of antibiotics. I don't know where that came from. I really don't know. My husband does a lot of work at SAMRI, South Australian Medical Health Research Institute, and there's some really hot scientists there in terms of microbiome research. And
Cool.
I've actually gotten to ask this question specifically because I used to get this all the time, and their response was, the same as mine. It's we don't know where that comes from. It is not really accurate. There is no such thing as lactobacillus overgrowth. And you need to look at the kind of testing that yields those results. So I think, again, just be judicious as to who is saying that and how they are testing specifically for that. And when you think about it, lactobacillus really does not make up a huge percentage of the bacterial population. So we kind of have this that's right, this idea that there's like these huge amounts of bifido and lactobacillus, and it's like, well, there's so many more. And these, they do have, they play a significant role in terms of health state, and we've got the research for it. So I never, if I see that, I go, no, don't worry about it. I'm happy you've got a lot of lactobacillus. Let's leave it there.
Yeah.
And let's not worry about it.
Let's not kill it, yeah.
Let's not kill it.
Where can people learn what you learn? Do you teach, do you mentor anybody else now? Have you written books? And if not, when?
No. Thank you. My book is, I've got the date now, it's coming out mid-April, but it is not a book that's related to this.
Right.
So I don't think that would be of use. I would say I've stopped mentoring in the last 6 months, just I couldn't fit it in into my schedule anymore. But I would say mentoring is definitely great. So just try and find someone who is, who's happy to do that, and just also keep going on to PubMed, Medline, and keep reading the research and experiment with these prebiotic fibers, because that's the great thing about these is that there are no side effects other than, if someone's got IBS and they're fructose intolerant, perhaps things like FOS might not work very well for them. But,
that's right.
But generally speaking, they're pretty safe. They're foods. So you can't really go wrong.
So last question, 5 favourite foods.
Do these have to be healthy foods?
No, they have to get an effect.
Okay, I'll say it. Sorry,
In kids.
you're talking about my, I was going off on a tangent. Okay, my favourite food, that's a great question. Okay, favourite foods would be chickpeas. Yep. Because everybody loves them.
Oh, yeah.
And they're very well tolerated. Artichokes. They're a little bit of an unsung hero, and I really like them. And the great thing about artichokes is that they can be an easy addition. You can even buy them in glass jars. So they're really great. Other foods that I love are coloured grains. That's a really great way to increase, the nutritional content and the polyphenol content of the food and how we're feeding beneficial bacteria. So that's a neat trick that I learned from Jason Horolac.
Coloured grains.
Coloured grains. So, generally speaking, we tend to counsel our clients to eat whole grains.
Yeah.
And so just go the extra step and say whole coloured grains. So, I love tricolour quinoa.
Right,
It's widely available. You can buy Australian-based quinoa as well.
Good.
Rices are really well tolerated for most people with digestive issues. And so if you've got someone who's really not tolerating grains very well, but rice is okay, then rather than just give them brown rice, you can get them to rotate their red rice, black rice, wild rice. They can be incorporated in breakfast. So there's probably quite a few foods in there actually that I've mentioned.
Yeah, well done.
The other thing that I love, probably my last one, would be again a neat trick is to cook and cool potatoes. Great addition for kids' lunches, and you're actually changing the composition of the starch.
Yes.
So that's really lovely. So you could do a few veggie sticks with some hummus and cold potatoes as a lunch, microbiota friendly lunch for kids.
Yeah. And that changes it into a resistant starch, which is going to feed not specifically, but certainly going to help along your bifidobacteria or the bacteria in your lower bowel, yeah?
That's right.
Yeah. Alessandra, I could talk to you for hours. There's so much that we could cover and there's so many different tangents, but, time permitting, I guess we have to cut it here. But would you join us for FX Medicine at other times? Because I got to say, I love the way that you think outside of a box and certainly outside of a commercial boxes that we're taught, and that practitioners grab so eagerly onto, and you go that extra step. For me, it's for the patient, and I really, really applaud you for that. You really, I doff my hat to you. It's very well done.
Thank you. I would love that. I really enjoy this conversation, so absolutely, anytime.
Excellent. Thanks so much. This is FX Medicine, and I'm Andrew Whitfield Cook. If you've enjoyed what you've heard today on FX Medicine, please engage with us and let us know what further topics you'd like us to cover. You can get in contact with us through our website fxmedicine.com.au or look for FX Medicine in your favourite social media platform. You can also rate and review us on iTunes, and we'd really like to thank those who have already rated us. It's through your continued support that enables us to bring you current, complex and relevant topics to enhance your practice of natural medicine.